All right, I think I've got some practice questions here. So, all right, some review cases / what you might expect from a test question from me. So, you've got a patient here who's a 52-year-old man with past medical history for hypertension, diabetes, and myocardial infarction 3 years ago. He has a urgent care with productive cough, fever, and malaise. Chest X-ray indicates left lower lobe pneumonia. Healthy enough to be discharged. However, you'd like to give him 1 dose of IV medication now and something to take orally at home. So which option would be best? Is there anyone that you guys can rule out if you don't know which the right one is? As far as what? As a correct or incorrect choice? No. So, thank you for guessing that. Or trying. Or educated guessing. I didn't mean it that way. I mean, thank you for stepping out of your comfort zone. Sorry, I'll rephrase. That sounded bad. I don't mean to put people down. Sorry. No, so the reason why that's incorrect is Zosyn's really, so this is a pneumonia, Zosyn's really broad spectrum, and you just don't need it to treat it. The other thing is that Augmentin isn't really a good oral equivalent to Zosyn. It lacks a ton of coverage, so you can't really just send somebody home on Augmentin after giving them a dose of Zosyn. So remember, we're thinking community-acquired pneumonia, so anybody know what pathogens we're treating? Strep pneumo, and what's the other group? Funny name. It's a group of things together. There's 3 different organisms in the group. They're not typical, but they are atypical. Okay, atypical pathogens and strep. So the drugs that cover that are really, there's only one option. Well, there is only one option here that's right. Remember, when you're looking at community-acquired pneumonia, there's a couple treatment choices which would be correct. If this guy was totally healthy and I didn't give you any past medical history, doxycycline might be an okay choice. C might be okay, but he's not. He's got some interesting history. I wouldn't consider him like the perfect model of health. So we're going to go up a little bit. So the only other options you can do are respiratory fluoroquinolone, which would be choice A. In this case, that's correct. Otherwise, B would be correct if you gave him something in addition to the azithromycin orally. So you can start with a ceftriaxone dose IV in the urgent care or emergent setting, and then discharge them on azithromycin PO. You just have to continue that cephalosporin coverage too. So you'd have to add like a 3rd generation cephalosporin on. So if I said ceftriaxone IV plus azithromycin PO and ceftonir PO, then that would be a correct choice too. But just azithromycin continued, even though you gave him a dose of ceftriaxone, it's not enough to cover the full course of pneumonia. So that choice would be correct. In this case, levofloxacin seems like the obvious choice, and it is. So that's what it comes down to. It's a popular choice for treating this because of that reason. You can go IV to PO really quickly and convert people. And you get really good bioavailability with oral Levaquin or levofloxacin. All right, case 2. This is EL. She's a 74-year-old woman. She's obese, has diabetes, and significant complications, including amputation of her left great toe 2 years ago. Her diabetes is poorly controlled. She's admitted to your inpatient unit. She has fevers and a new deep necrotic ulcer in the sole of her right foot. She, not having any recent culture data, what antibiotic strategy is best to start at this time? C. C is correct, so yeah. C is the correct choice. So you want to go broad spectrum with a diabetic foot ulcer, especially somebody who has amputation history with complications, poorly controlled diabetes. Remember, diabetic foot ulcers are deep infections. You don't know what's growing in them. And you want to cover 3 main things. That's going to be, unless you have culture data to go off of now, this is empiric therapy, so I gave you that we don't know what we're treating, so we're kind of taking a shot in the dark. We're going to cover broad. That includes, resistant gram-negatives or gram-positives like MRSA, difficult to treat gram-negatives like Pseudomonas, and then anaerobic coverage too. So that's what Zosyn and vancomycin are going to cover. Vanco giving you the MRSA coverage, and Zosyn covering everything else. The other ones would be wrong because A doesn't include MRSA therapy. B is just Vanco, so it's only including MRSA therapy. And then D, cefepime, it's pretty close, and you could maybe make an argument for it, but it doesn't have anaerobic coverage, so that's where Zosyn has an advantage there. Okay. So pretty easy stuff, right? Antibiotics are challenging. So hopefully, I don't know if you guys have all gotten a chance to listen to the recording I did last week, but if you didn't, I'd really encourage you to think about doing it sooner rather than later. It's got a lot of good examples in it and covers a lot of the antibiotics, some of the stuff we just talked about. Okay, so antifungals. Antifungals are just a group of drugs that I'm not going to spend a ton of time on, and I'm not going to ask a lot of exam questions on, because for the most part, there's not many of them that a general practitioner would use. And I know many of you might go into specialty areas, but for those who do, I want to cover that stuff briefly. But a lot of this stuff is going to be restricted to ID. You're going to want specialists involved for prescribing it. People who are at risk for fungal infections, immunocompromised patients. So if you work with HIV, transplant patients, cancer patients, that's going to be your primary group of people who are at risk for these types of infections. And people who are on broad spectrum antibiotic use too, due to possibly being critically ill, weakened immune system, and nosocomial pathogens and fungal infections creeping in and taking advantage of that situation. So you might see that happen too. Usually in most patients, regardless of their immune status, sometimes if they know if there's an obvious fungal source, so you get a sputum culture and you send it to the lab and they're like, it's growing aspergillus, definitely fungal. You might get a clue in, but generally speaking, you're going to treat somebody with broad spectrum antibiotics first, and then you might add the fungal therapy later if they aren't responding in a couple of days, so if they're still febrile, still look sick, and they meet some of that immunocompromised criteria. That's where you really see antifungals as major treatments come into play. Of course, there's some you can use in the outpatient setting too, but there's really only one drug that's applicable to most people. So we'll cover that. We'll cover a few other ones here, but just know that these are more of a specialized treatment. Okay, so we've got yeast, molds, and mushrooms, different types of structure than our bacteria, so we treat them a little bit differently. A lot of it's targeted at destroying the fungal cell wall, as far as mechanisms go. And these are just the infections that might be more or less common. Candida is probably the most common group of infections, anything from like oral thrush to disseminated infections too. There's lots of different species of Candida. So there's like Candida albicans, which is responsible for oral thrush and things like vaginal yeast infections, and things like Candida glabrata and some other ones that are much more resistant. So depending on what Candida species you're working at could direct your therapy much differently. I've got a number of different ones here that you might see in, again, immunocompromised patients, so like blastomycosis, histoplasma, aspergillus, and cryptococcus. Again, these are all really for the immunocompromised patient. These things are everywhere. So aspergillus is a really ubiquitous fungus in nature, and so you and I get exposed to it all the time. But we have functioning immune systems for the most part, hopefully. And if you don't, that's where it can get nasty. So again, they're opportunistic. So just think of them that way. With the exception of some Candida species, most of these are going to be pretty rare to see in clinical practice. If you want to refer back to this and how they work, so again, we're looking at cell wall / cell membrane. I should have said that to be more clear. But most of the drugs are working on our cell wall or cell membrane of the specific fungus. And this will show you the different drug classes and what the drugs are and then what their mechanisms are. So if you want to use this as a reference slide and refer back to it, you certainly can. I'm just going to start sort of in alphabetical order and go through them here. Amphotericin B is a really old antifungal agent that was fallen out of favor completely because it destroyed people's kidneys. It does have very good broad spectrum coverage, and it can be useful for things like cryptococcal meningitis. And that's something that we see sometimes in really advanced HIV patients as a common deadly infection that they might get if they're, and George is going to talk all about CD4 counts and stuff like that. Once their immune system gets depleted, they're at high risk for these types of things. Ampho B, again, renally toxic. However, it's been reformulated in recent years to what's called a liposomal formulation, which means it doesn't get into the kidneys very well at all, which is good because it allows us to use it without destroying people's kidneys. In most cases, with the old formulation, creatinine clearance can decrease back to 40%, and that's direct from toxicity. That's not like a transient change in serum creatinine. It is usually reversible unless you give really high doses for long periods of time. So want to make sure you're being careful if you're ever using this drug with just fluid intake and things like that. But again, the current formulation, especially the liposomal, is the only one I've ever seen used recently, and that's supposedly the best tolerated one. Still some risk, but not as much as the original formulation. So that's really, from my perspective, all I want you to know about Anti-B. Broad spectrum, has renal toxicity associated with it. Okay, azole antifungals are going to be the most common class of antifungals you're going to encounter. Just some general things to remember about any azole antifungal, and this is an important thing because as far as drug interactions go, you never know what type of patient you're walking in on. Maybe you have a patient in your primary care clinic who takes chronic fluconazole because they get recurrent thrush or something like that. What that's going to affect is their CYP enzymes pretty significantly, and azole antifungals are one of the biggest across-the-board enzyme inhibitors out there. So if you ever see somebody on a drug that's an azole antifungal, that's a red flag that you're going to have drug interactions to worry about. So if you're ever prescribing something new, just make sure you understand what the potential clinical risk of that interaction might be, as most drugs will be affected to a certain degree by an azole antifungal interaction. Spectrum activity is really wide. We have really narrow, very basic drugs in this category to pretty broad spectrum ones. And they are generally avoided in pregnancy, which is a little tricky when it comes to things like, vaginal yeast infections in a pregnant patient. However, short courses of a drug called fluconazole, which we'll talk about in a second, have been shown to be okay. Ketoconazole is mostly a topical use, but it's also available as a tablet, so topical candida infections, and there's some other ones that would be useful too, but mostly you're looking at topical, either in a suspension form, so maybe orally, could be given. Most of the time it's used as a cream, so if you get some sort of or candida-related rash on the skin, this would be a drug that might be useful that way. Fluconazole is the one probably all of you guys will encounter at some point or probably prescribe at some point in your careers, assuming if you work in family practice for sure, but I'm assuming everybody might have the opportunity to prescribe this at one point in their life. Fluconazole, or diflucan, is the brand name of this, and it's really the common one for basic candida infections. It's nice because it's a one-time dose for both oral thrush and vaginal yeast infections, and it's pretty effective. So what I just talked about with pregnancy, we said generally not useful. However, in this case, all the studies around fluconazole that showed risk in pregnancy were high doses and sustained durations of therapy, not one-time doses. For the most part, all one-time doses have not shown any risk in pregnancy, and they've looked at tons of data for this. So we're pretty confident it's safe. So that's the one caveat with the pregnancy thing, is that the one-time doses are okay, which is great because this is a good agent to use in these situations. It has about a 30-hour half-life, so that's why you can get away with those one-time doses. You get a couple days worth of blood concentrations that are high enough to clear the infection. And you can do higher doses and more sustained dosing as well. So like for candida, like a candida fungus that's infecting the central nervous system of a patient, you can give a IV therapy and do daily that way. So you can definitely do a more aggressive therapy with fluconazole, but it's certainly appropriate for the commonly used oral stuff too. So it's a nice drug that way because it comes IV and oral. Sporonox, or itraconazole, is a PO only one, and I'm not going to ask you any questions specifically on Sporonox on the exam. I don't really care that you know what it's used to treat. If it comes up as a choice on my exam, it's probably not the correct one. That's what I'll say. Voriconazole is probably the other one in this category worth knowing, and it's because it's a nice broad spectrum IV antifungal agent, and it's a really good choice for aspergillus. And aspergillus is one of the most common pulmonary infections from the fungal group. So remember, we're talking about fungus here. Fungal infections in general are pretty rare, but if you're going to look at a more common serious one, it's going to be aspergillus. And aspergillus can be pretty deadly, but voriconazole is one of the drugs we use to treat it. If you had a candida infection that was resistant to maybe some other things, remember I talked about there's Candida albicans, which is your standard candida. There's other candida species like Librata and Crucei, and those ones are a bit more nasty and tend to be more resistant to fluconazole. So that's where voriconazole comes into play. It usually works well for these agents. It does have some interesting side effects. It causes this halo effect in the vision and also hallucinations. That's the most common ones, is vision changes. So if your patient is on Vori and they're telling you they're seeing angels dancing on their bed, they're either, well, I don't want to say that, it's mean, but they're probably just hallucinating from the drugs. I don't think they're need a stat dose of some kind of an antipsychotic or something. And then posaconazole is a pretty broad spectrum oral suspension, so it's an option for somebody with oral therapy, kind of like the same thing with itraconazole here. Again, I'm not going to ask you too much about broad spectrum oral therapy. You really care for azole antifungals. You know that voriconazole is pretty good aspergillus coverage, and fluconazole is sort of our first line for those basic, thrush type infections. Echinocandins, I think how you say that. I don't know, I might have just made that up. You can use your imagination to think of more creative pronunciation for that if you want. These are really nice drugs as far as antifungals go. You're not going to see these used all that much. They're broad spectrum, well tolerated, and super expensive, but they have virtually no side effects. They do have some drug interactions to consider, but for clinical uses, they're going to cover a lot of things. So if you started somebody on voriconazole for invasive aspergillus in the lungs and they aren't responding to it, this is probably your second-line therapy. In fact, some people would argue these should be first-line therapy because of their tolerability for most patients, and that's okay too. There might be some recommendations that this might be a hospital formulary item where it's like, yep, we use caspofungin for all of our advanced fungal cases. So there's some data that says for certain patients that are in an ICU setting and have respiratory infection to meet certain criteria for how critically ill they are, that you should just empirically use antifungal therapy. We don't do that. Some hospitals might, so it just depends on where you go. We usually wait and see. I put the drug interactions up there, and this is going to be more important when we talk about transplant medicine, because those are all anti-rejection meds, with the exception of nifedipine. It's a calcium channel blocker for blood pressure. But the other three are all anti-rejection meds. So when you're talking about antifungal infections in transplant population, those two things go hand in hand. So in those patients, they're at pretty high risk because they're immunosuppressed due to their medication regimens, and they're going to be ones that could be qualifying for these types of drugs. So just to understand that there are some drug interactions. If you go into transplant medicine, which we do have a fair number of APPs that work on our transplant team, so it is a viable career option for you guys. But it's just something to keep in the back of your mind if that's an area you want to practice. I'm not going to ask you test questions about drugs we haven't covered and drug interactions, so don't worry about that too much. They are IV only, so you can't transition people to PO. Adverse reactions, again, very minimal. You might get some infusion-related reactions, maybe a headache, but every drug in the world, if you look up its side effects, causes headaches. So that's not really something we put too much stock in generally. Yeah?
Can you say in general that, like, if you're going between two meds, that if it is IV and PO, always pick that one over just the other?
Yeah, it kind of depends on what the patient's course is going to look like, how long they're going to be in the hospital for, and how long you might be able to get away with IV treatment for. If you're thinking they're going to discharge in a couple days, definitely. If they're looking at an extended stay in the ICU plus rehab, then it doesn't really matter what you're going to do. Okay, topical antifungals are available for all types of tinea skin infections. So these are things commonly referred to as things like ringworm and jock itch or athlete's foot. They're all different types of tinea infections. There's a number of them on the market. Terbinaffine's another one that has a slightly different mechanism, but it's also a topical. And there's another one out now too that's branded. They're all branded differently, like they're all variations of Lotrimin products or whatnot. But if you look at the actual active ingredients, they might differ, or whether they're clotrimazole or something else. So. Topical creams and suppositories like Monistat are usually clotrimazole or miconazole. So if you're wondering what Monistat 7 is, it's miconazole. And those are alternatives those might be a good alternative for a pregnant patient who's like, no, I don't want to take anything that even has remote risk for fetal complications, so I'm not going to take that oral fluconazole for my infection. And you're like, well, okay, we'll give you a topical product in that case. But usually the oral therapy is better at getting rid of the infection than the topical is. Certainly worth a shot. All right, so if you're wondering and you're doing some reviewing, like, okay, what's more broad spectrum, what's not, this does a pretty good job of explaining it, I think. So you can see, for example, here, fluconazole doesn't have much coverage outside of your Candida friends. Once you get into the other ones, they have a variety of coverage. Here's amphotericin B, remember, pretty broad spectrum, but maybe a little bit toxic. But it does have some coverage down here that you might not get with our kind of candidates that we like. But, the odds of you seeing stuff like this, it's like, don't put too much stock in this, but if you want to do some comparison. The point is that fluconazole is not very broad spectrum, and pretty much all the other ones I want you to know are. So that's the big difference here. And side effects, again, amphotericin B, renal toxicity, voriconazole, maybe some CNS vision disturbances. Otherwise, if you want to look at these for your own reference, they're there, but I'm not going to ask any questions on them. Okay, malaria. So fortunately in this country, malaria is not a huge deal. We don't have a lot of active malaria cases, especially in Minnesota. However, nationwide, it's one of the biggest killers in the world. And in fact, 300 to 500 million new infections, 1 to 2 million deaths per year. So it's definitely an important international medicine topic and tropical medicine topic. We just don't see it a lot in Minnesota, and when we do, or in the U.S. in general, I should say, when we do, you have to call the CDC. Like this actually happened to me 2 weekends ago when I was working. I had to interface with the CDC dispatch person in Chicago to get a special drug flown into our hospital. And then the United Airlines lost it. And anyway, we didn't get it for a number of hours, so that was great. Because it's like, and the guy sent in this email, it's like, we have depleted our supply in Chicago, please restock immediately. So it's like, well, if this is lost, we're kind of screwed. And the ID doc's calling me at like, I'm about to leave, it's 11 o'clock at night, and she's like, where is it? Is it started yet? I want to go to bed. I'm like, I don't know, I'm going home. So anyway, it's tricky to treat in the U.S. because it's just, we don't stock the drugs. They're either investigational or expensive. So for the serious, infections that are going to put people in the hospital. If you're doing travel medicine or family medicine and somebody's going on a trip, the CDC has a great reference for countries and your risk and what drugs to recommend for prophylaxis. So that's really what we're going to be talking about for the next few slides here. And I just took a snapshot of the first few here. So it shows you, like, for example, if you're going to Afghanistan, you have a high risk of malaria there, drug resistant to chloroquine, and then the recommended prophylaxis. So you have all that displayed. So if somebody's like, I'm going to go to American Samoa, which sounds probably like a pretty nice place to visit, you can look at this and say, wow, there's not really any risk. You're good to go. You don't need malaria prophylaxis. So there you go. Of course, people can access this on their own, but you can guide them through it. Yeah.
Can you comment on Mexico? I noticed that was red. Like, tons of people travel there, and I've never done anything prophylactic.
Oh, no, I can't comment on that. I'd have to look it up. I think it might be, I don't know if it's cases or what.
Okay. I was just wondering, like, did red mean
I went
high risk?
I went on a trip to rural Mexico in school, and I didn't take any prophylaxis. So
yeah, okay.
Maybe it's, I don't know. You have to look it up more. That map might be made up. I probably pulled it off of Google. Yeah. I should have used the CDC. I went outside my comfort zone there. Okay, so the CDC has this nice diagram on how this all works, and I'm not going to spend too much time talking about it. It's a mosquito-borne pathogen. I think most of us have learned about this at one point in our schooling, so I'm not going to reiterate it today. But prevention is a big deal. So regimens vary in cost, adverse effects, and dosing schedule. And that's really what you're going to focus on here. And again, the CDC guide is key for understanding where the person's going and how to tailor that specifically. Okay, Malarone is the most popular one. It's for good reason. It's pretty well tolerated overall. It might have some GI side effects, so diarrhea, nausea maybe. But it's pretty commonly used because it's a nice, easy regimen. You take 1 to 2 days before and 7 days following. It's about as easy as it gets. And you take every day during. Everyday regimens are, in my opinion, way more preferable than like a once-weekly regimen where people are probably just going to skip a week and then realize the next week, like, oh, shoot, I forgot. Like, for example, look at methloquine here. Take once weekly, start 2 to 3 weeks before and 4 weeks after. So you take 1 time a week, every week, right? And what happens after you're back for 2 weeks? And you're like, oh, I feel great, I forgot. And technically you didn't finish the course out. So a lot of these drugs are not ideal. Malarone is probably the perfect world here. It's a little bit expensive. That's its biggest downside. But honestly, I'd pay the cash price even if my insurance didn't cover it, so I wouldn't have to take any of these weird ones. Now you might get in a situation where Malarone's resistant. It's one of the better drugs out there for resistance, but still there's resistance in different areas of the world. So that might be a stumbling block too. But again, check the CDC guideline if you have questions. I don't think Malarone is preferable in pregnancy, so that's one I don't have up there, but a couple of these other ones I talked about is preferred in pregnancy, and that's one of the reasons. So that's another maybe downside of Malarone. But if you're not pregnant, you can afford the drug, and you're going to a place where it works. It's the first line therapy for sure. Lyrium or methloquine is an older drug. It's got a nice side effect of psychiatric effects, including nightmares and paranoia, which is going to be 5%, which is a decent amount of incidence for pretty severe mental illness side effects. Certainly if somebody has a history of mental illness, probably would want to avoid this one altogether. And one recommendation, if you are going to do this, if you have a pregnant patient and they don't really have a history of mental illness, you could consider it, but maybe start it a week early. So do 4 weeks early, have them take it for a week and see if they're going to have these psychotic dreams or anything like that that's sometimes seen with methloquine. Doxycycline can be used for malaria too, and usually not. It's more going to be common for places where there's resistance to other things. But it's certainly an option. It's sort of an easier regimen, 1 to 2 days before. It's a daily dose, 4 weeks. It's a twice daily dose, I should say. 4 weeks following. So you do have that long period following where, again, Malaron's only a week, so it's a little bit inconvenient. Usually pretty well tolerated. Doxycycline can cause some sensitivity, which isn't usually compatible with where people are going that have malaria endemic there, but that's part of the risk that you take, I guess. And then pregnancy wouldn't be an option for doxycycline. Chloroquine is a once weekly, 1 week before, 4 weeks after. It's pretty well tolerated overall, and it's safe in pregnancy. African and Caribbean descent people can have some itching with it. Apparently it concentrates more in their skin than with people of other ethnicities. I'm not exactly sure why, but that's just the side effects that are reported. Otherwise, it's pretty well tolerated for most people, and it is safe in pregnancy. So this might be a nice alternative to methylquine. The chloroquine resistance is really common, so it's probably not going to be an option for many places you travel, unfortunately.
You said African and what?
Like at black generally, so African Caribbean descent. Primaquine or primaquine is a pretty easy regimen, similar to Malaron. It's got some kind of nasty side effects, including a slight risk of hemolytic anemia and some GI upset associated with it. It's contraindicated in pregnancy and breastfeeding, and not likely to be a huge option. And then the active infection. So again, you have to call the CDC to get special drugs for this category. So I'm not going to ask you how to use coartem or anything like that, because you're probably never going to have to do that in your career. If you go into ID especially, or if you go abroad, you might. So I should say never, but it's going to be unusual, especially in this country. So just know they're IV only. You have to go through special channels to obtain them, and your pharmacy is going to be like, "What? You want me to do what?" And you might have to do a lot of coordinating on your own. I was nice. All right. It's perfect. George should be here a second. I've just got a couple slides left. Parasites, not much to talk about here. Giardia is a common diarrhea-related parasite. It's through fecally contaminated food or water. It's really all over the country. You can get it from animal feces or untreated water supplies. Pretty severe diarrhetic cramps, abdominal pain, bloating, flatulence. Metronidazole is a pretty effective treatment of this parasite. It's the drug of choice. Helminthic infections, worms. So I've got some Dumb and Dumber references on here for those who think that's funny. Multicellular organisms. These are really common in people, and a lot of people can carry a decent amount of helminths without knowing they have it, especially in developing countries. But it doesn't mean that's good for them. So usually they're intestinal, so most people don't have a lot of complications other than they might be malnourished because the worms are absorbing nutrients they should be. You can get neurologic and other types of complications with them as well, though, depending on how severe the infection is. Roundworm, whipworm, hookworm, and pinworm. Treatment is mebendazole or ivermectin. These are both useful. They destroy the larvae via degeneration of cytoplasmic microtubules at the cellular level, and they're treated in pretty short courses, and they're very well tolerated overall. Ivermectin, I think, is a little bit more toxic than mebendazole, so mebendazole is the preferred choice. Side note, ivermectin is a PO topical for lice in people, but not something too critical for knowing for this exam. Flukes would be something like we might see in Minnesota summers from snails that pass these and beaches. So schistosoma is another one. Swimmer's itch. Praziquantel is a medication used to treat this. A lot of times people don't necessarily take oral drugs for these, but you can, and that's going to be the drug of choice here. Dizziness, headache, possible fever, and malaise are common side effects of praziquantel. Tapeworms, you have various undercooked meats, beef and pork. Most of the infections are going to be subclinical, but again, these are the ones that could spread to muscles and have neurologic involvement. Usually it's associated with animal waste contaminating human drinking water. So places where they don't have as good of water quality as most places in developed countries. So developing worlds are going to have a much bigger problem with this than we are generally. These can be quite nasty if they get out of control, especially in the central nervous system. But the treatment's pretty similar. We're using albendazole, which is kind of a similar drug to mebendazole. It's in the same class, and praziquantel as well for these. So that's some nice pictures that should haunt your dreams if you're scared of like parasites potentially. The top one, I think that's a muscle of an animal that was infected with specifically. I can't remember if it's pork or beef, but yeah.
Is there a reason these ones aren't highlighted, like bolded?
Yeah, I don't know if I didn't bold them for a reason. I don't think I'm gonna. I might ask like one question on helmets, so that's probably what it is. Well, they're the same drugs as the other slide. I mean, albendazole and mebendazole, they're essentially the same thing. I don't know if one's IV, maybe, and albendazole comes IV or something. They're really rare. You don't see these used all that much.
On the malarial, are we to assume you say a couple days before and then a few days following the trip, but always take it while you're there?
Right. Yeah, you're always taking it. You're always taking it during the trip. So if it's a once weekly, it's the weeks you're there. If it's once daily, it's all the days you're there. Yep. Exactly.
It's just not stated on the
Right. Right. Yep.
So in general, is it the bolded?
Be careful with that if you have a question about whether one is. So the only time I think that really applies, I'm trying to think, is like some of the penicillins I tried to bold. There's some that aren't bolded, like ticurcillin. I'm not going to ask any questions about that. There's some cephalosporins I didn't bold, which I won't ask questions about. But for the most part, yeah, if there's a slide dedicated to something and it's not bolded, it's probably a safe bet that I want you to know that medication if there's an entire slide on it. So, you know, if there's a question like, you know, do I have to know praziquantel or albendazole? I mean, they're bolded on this slide, but not on this one. So. I don't generally use the bolding too much. I was trying to do it to highlight things. So, I don't know. Sorry if that's confusing, but if there's one that you're like, do I have to know this one? Just email me. But generally speaking, yeah, slides dedicated to things, drugs I spent a lot of time on. If it's not bolded, it should be probably obvious that it's covered. Yeah. Yes.
For the roundworm slide, when you talked about it, did you give a kind of a dosage for that?
No, I don't even know what the doses are. I've never seen these drugs prescribed, to be honest.
Are they like a one-time dose?
A short course is all I know. I think I looked it up, and I want to say that probably means between like 3, 5, 7 days, maybe nothing longer than that.
When do you use the ivermectin instead of the mebendazole for the roundworm? Did you say? Even though it's
No, I would say they're interchangeable. So maybe if they weren't getting better, I think it's a little bit worse tolerated. So you'd try the mebendazole first,
okay.
and then if they didn't respond, you could try the ivermectin.
Okay. And you said something about it was used topically for lice, so like.
It's a shampoo.
As a shampoo.
Yep.
The same dosage and everything.
Well, no, because this is PO. So it comes as yeah, it's an alternative. Yeah. Yep. Well, yeah, it's kind of, yeah. We'll talk about that a little bit during derm, more like the topical ID stuff. I'll come back to that. So, questions in the back.
Should we focus on like dosage?
No, the only doses I want you to know are the STD dosing for ceftriaxone and azithromycin.
What length?
So I will be very specific throughout the entire course that I'll tell you what I want. Every once in a while, I might want you to know frequency. So like if, for example, there's 2 treatments we talk about. I don't think anything really applies here. I'm trying to think if there's there's some times where we talk about, like, maybe we'll talk about a blood pressure medication, and maybe one drug in the class is once daily and one's 4 times a day. So the once daily one's probably going to be preferred for compliance purposes. So I might want you to know that type of stuff. I don't know if anything really applies here, because most of the drugs, even if they're multiple times a day, when it comes to antibiotics, we're still going to use them. We don't really ignore them because of that. So, you know, there might be benefits to those once daily ones, but it doesn't mean we don't use the other ones. So, but I won't ask you like milligrams for this test outside of those 2 for STDs.
So should we focus at all on the amount of time for those antimalarial prophylaxis?
No, I just focus on convenience. So like if I asked you a question on which one would be, if a patient was saying that, you know, if I gave you something in their history saying that they were non-compliant or something like that, maybe consider one of the more easy regimens than the longer ones.
Can you say which STDs, or is it all STDs you want us to know?
Well, it was in the recorded PowerPoint pretty clearly, I think.
Oh, sure.
Yeah, it was on that. It's that one slide about chlamydia and gonorrhea. Yes.
Do you have any general study tips for us, like the best way to study? Or?
It's a good question. I've never taken one of my own tests, Cole. General study tips, I would say, if this is new, I mean, a lot of you guys, this is new for you, but if you don't have much history with drugs, just make sure you can classify them appropriately. And I think antibiotics comes down to, it's a little bit different than the rest of what we're talking about because there's so many different systems we're targeting. But just think about coverage. So look at their mechanism, or not, group them maybe by mechanism of action or class or however you want to describe it that works for you. And then look at what types they generally cover and then try and break them down that way. So if you want, think about infections this way. If they give you a patient that's septic and they give you a lot of critically ill factors in that's going to be broad spectrum. If they give you something that's more outpatient, or I say you want to discharge them on something to go home with, that should lead you towards maybe a less broad spectrum therapy. So think about drugs in that terminology where you're like, okay, what are the big guns, what are the small guns? And then you have to categorize them by how to treat different types of infections. So I think it's a lot of just going through it and looking at how you match them up. And I think they start to make sense once you get used to antibiotics a while, but it does take some time to put.
So can you say that if you're going to send them home, you want to use...
You're usually going to use more narrow spectrum stuff just because patients who are going home aren't as critically ill. So there's usually a more targeted focus. Like fluoroquinolones is probably the most broad spectrum antibiotic you're going to ever discharge somebody on to take orally on an outpatient basis. You're never going to treat somebody with pseudomonal drugs usually. I mean, usually you might get a weird case where you have pseudomonas in the urine or something that responds to a specific drug, but for the most part, you're looking at pretty basic pathogens for outpatient treatment. Be familiar with being able to interpret resistance from a lab. There will be a question on that, and I think there's a good example there. I know there's a good example on the case review I'm going to post that shows you how to walk through some of that stuff too. So that should be a nice review for you guys. But go back to those slides if you have any questions on that and look those over, because I want you to be able to know if something's susceptible or not. So I'll ask you a question. It might read like, I think I post some examples of this too. So anyway, I'll just say it, but I'll post an example that'll say, this is the sensitivities of this particular pathogen to these antibiotics. And then I might say, you started them on X drug and now it looks like it's resistant. So what do you want to do? And so you have to interpret it that way and look at, what's sensitive first of all, and then use your knowledge to say, well, okay, what do I know would be a good option for this particular infection to treat? And then you should be able to come up with the answer that way, hopefully.
And the case studies or whatever you said you'd post.
Yeah.
In the next.
I'll post them tonight.
Are your test questions going to be typically be case-based?
Yeah, the trickier ones are. I do ask a fair amount of simple questions too. Like I might even ask, like, what's the mechanism of cephalosporins in general? So is it like a cell wall agent? Is it ribosomal DNA type stuff? Like what type of category does it fall into?
Okay.
But yeah, there's a mix of that. A lot of them are case-based. And then I'll tell you what to know for Georgia's portion so you don't totally freak out. All right.
Are you going to post